Our first speaker is Dr. Rauh. He's a clinician-scientist in the Department of Pathology and Molecular Medicine at Queen's University. He obtained his MD PhD training at the University of British Columbia and the Terry Fox Laboratory of the BC Cancer Agency, and did his residency at the University of Toronto in the HemPath at the University of Toronto. His objective is to transform myeloid cancer practice and research by shifting the focus to the earliest genetic and immune alterations, leading to the earlier detection, improved prognostics, and targeted treatment. So please welcome Dr. Rauh.
Thanks, Morgan. Thanks, everyone, for being here today and for this invitation. I'm going to ditch my jacket.
Thanks for coming out here. It's a rainy day.
Yeah, well, I mean, it's a big day in Toronto, right, with the Raptors. So hopefully they bring some, sunshine later on. But on a lark, I looked at prices and I thought, no, I can't do that. So I will be talking about personalized molecular pathology for myeloid cancer diagnosis. I like this context of adaptive oncology. So I've been fortunate to be funded by the Transformative Pathology Division, now Diagnostic Development, and the Ontario Molecular Pathology Research Network. But I wanted to gear the talk today to this, and this really resonates with me. So monitoring cancer over its life cycle. I'm going to talk to you about what we do now, but really, I'm really excited about what's coming down the pipe, looking earlier on, and to enable precise and proactive clinical management. Okay, so the first part of the talk, I'll describe the grant we have and the objectives we have with the Ontario Molecular Pathology Research Network. Essentially, as patients currently present, applying next generation sequencing panels to improve diagnosis and clinical care. But the second part is thinking in the frame of back to the future. So using the sensitivity of NGS to identify the origins of myeloid cancers. And this is a very exciting concept. And I want to talk a little bit about this and potentially how we might mitigate risks of associated with this clonal hematopoiesis. So when I started as a resident and as a junior faculty, identified as an area of need as a pathologist, myelodysplastic syndromes. These are clonal disorders of bone marrow failure where the bone marrow stem cells are defective. They produce abnormal looking cells or dysplastic cells, and this leads to low counts in the periphery. And these can also transform to leukemia, acute myeloid leukemia. So to diagnose this, we need unexplained cytopenias, so low hemoglobin, platelets, white cells, and at least 10% dysplasia in at least one of the myeloid lineages. So this is what we train for as pathologists on the right side of the screen. It's meant to be very objective, looking for dysplasia in erythroid, megakaryocyte, and granulocyte lineages. But the reality is it can be quite subjective. So what can help us on the bottom is if the patient has an increase in primitive cells called blasts, that's helpful. And if we find a cytogenetic abnormality, that's also helpful to assist the diagnosis. But usually these two are absent in the early phases of MDS, making it really challenging. The other feature is that there are imposters out there. So we have to be very careful because dysplasia can result from reversible causes such as nutritional deficiencies or medications that patients are on. So, this is kind of a bedside back to the bench. We needed some help here. It's not a great area. It's hard to diagnose. We can do much better. Around the time I got my lab started, there had already been genome-wide efforts, whole genome, whole exome sequencing, identifying recurring mutations in MDS. There are a whole bunch of them, but there seems to be a finite number of recurring ones. And interestingly, primarily affecting RNA splicing or epigenetic regulators, such as those that regulate DNA methylation or histone modification. So this was perfectly amenable to targeted NGS, and that's what the Transformative Pathology Fellowship initially involved. So I want to show you now an example of when we apply a targeted NGS to the problematic area, the difficulty in diagnosing early MDS. And for this, I used a 48-gene custom ion torrent panel. So in yellow, as a resident and junior faculty, I gathered about 18 cases from Sunnybrook and Queen's University, where we were at an impasse, at a standstill. So the clinician was wondering, is it MDS? The pathologist, in applying the tools that we currently have, could not arrive at a diagnosis, but was suspicious there might be something there. And we also sequenced patients with diagnosed MDS. What we found was that a high proportion of these did contain mutations, albeit slightly less mutant on average here we see the medians, than true MDS. So maybe the fact that there are a few less mutations explains why the morphological dysplasia is not quite meeting the threshold. And especially mutated in this earlier phase were the top genes I just mentioned, epigenetic and spliceosome regulators. Where we were surprised was when you look at the variant allele fraction in these suspicious cases, it was identical to MDS. So the clone occupies the same amount of space in the blood and bone marrow, just slightly less mutated than those cases that met that morphological threshold. And so because these are often heterozygous mutations, somewhere in the order of 80 to 90% of cells are mutant, but we're just not able to make the diagnosis with the microscope alone. So now I'm going to introduce some four-letter words, and some people kind of curse to see these and keep up with them. But so let's add in now in the yellow zone. These are patients with CCUS. So that's now called clonal cytopenia of undetermined significance. So they have cytopenias. The dysplasia is not meeting the threshold, and the NGS has helped us to identify that they have a clonal origin to their disease. So that's CCUS. Now, not intentionally, but in sequencing patients in other situations, sometimes we notice mutations, so clonality, in the absence of any cytopenias or any dysplasia. So CHIP will come up a little bit later, and there's interest obviously in Toronto in CHIP, also known as ARCH. But in the meantime, others have been looking at this, including our group. This is from an Italian paper. So if you have CCUS, you're at an increased risk of eventually developing a myeloid neoplasm. And in fact, some CCUS, so certain combinations of mutations, essentially resemble low-grade MDS with respect to patient survival and the propensity for leukemic transformation. So this is likely going to impact our ability to diagnose MDS earlier. A couple of key developments also that led to the OMPRN grant. So every once in a while, the World Health Organization will update the classification of system for cancers. Here's the hematopoietic and lymphoid. This happened in 2017, and of course, we're adding in more molecular features. And we were otherwise ill-prepared to capture all of these with traditional molecular kind of single assay approaches in the lab. So we need higher throughput approaches. Because of our success with the AmpliSeq, we were granted early access to a combined DNA RNA panel from Thermo Fisher. We already had NGS and Ion Torrent in a certified setting in our Health Sciences Center. And with the OICR grant and mentorship of Dr. Bartlett and a co-investigator, we were poised to apply this. Here is the panel that covers 40 genes, either hotspots where that's important or full genes. So for example, TET2, you can have mutations that are inactivating, occurring throughout. And 29 fusion drivers that covers around 700 possible RNA fusions that occur from chromosomal translocations or inversions, for example. Another key development is that in 2016, I was invited with Dr. Feilotter at our center to advise Cancer Care Ontario regarding laboratory recommendations for complex malignant hematology testing. And the advice of the panel was that we need panel to approach this. So this is ideal for NGS panel testing in myeloproliferative, dysplastic, overlapping, and leukemic states. So there were two objectives of the OMPRN grant, which we were just wrapped up and are analyzing the data now. The first was to implement and validate this new tool in the clinical lab. And another important point was to demonstrate the clinical utility and to inform some research. And for utility in bold, so we'll focus in the interest of time on the utility side. What we defined as useful was when it helped the pathologist to achieve or clarify the diagnosis, or if this informed for the patient and clinician the risk profile and the follow-up that was necessary in the clinic, or if there's available drugs to target genes, or if it affects decisions regarding bone marrow transplant or clinical trials opportunities. So I'll talk to you now, just hot off the press, about in the 1 year of time where we captured 131 samples from 121 patients, which span the age range that you see there. The catch is that initially when it rolled out, Cancer Care Ontario funded just the acute leukemia cases. We don't get enough acute leukemia cases in Kingston, and so we leveraged these funds to sequence other cases, non-leukemia cases like MDS, to fill the sequencing run. So the hematopathologist, like including myself, triaged and decided which samples to put in the queue to fill the sequencing chips. And with this triaging, we end up reporting variants in about 2/3 of samples. And these were variants for the most part that we would not pick up by any other means. Here are the mutations just by frequency from top to bottom. I won't dwell on this one now, but it's the usual suspects. We are going to be analyzing this by disease specific, but the top two genes we found included TET2 and SRSFR2. Now, from a pathologist standpoint, it's interesting how this affected, first of all, our ability to diagnose or clarify the diagnosis. So what I'm showing you here is before and after NGS. So AML, we can diagnose under the microscope if you have at least 20% blasts or by flow cytometry. So we don't need the NGS to diagnose the AML. We can stratify the diagnosis a bit. So it didn't impact our ability to diagnose it. But where it had the greatest impact for diagnosis purely was when clinicians were wondering, does this patient have MDS? Do they have a myeloproliferative disorder, overlap disorder? That was where we really made an impact in clarifying or achieving the diagnosis. Now, the next stage is how actionable are these mutations? So we determine actionability, the definition I just provided, in the context of the patient's clinical history, chart review, in the context of the pathology report, as I'll get back to, and with some tumor board review that involved the molecular geneticist, pathologist, and clinician. Now recall, these are triage specimens, and so we're trying to apply where we think it's going to be useful, and not surprisingly, we by these definitions achieved high actionability, so 72% of the variants. Shown on the right is most common was that it affected diagnosis. Some also affected prognosis and management, and you can see how they overlapped as well in that Venn diagram space. Now, this is showing you the frequency of mutations and by individual gene. So a couple of things to note here. There are some genes that were always actionable. So for example, BCR-ABL and PML-RAR. So the RNA fusions, these either have a targeted drug available or they provide important prognostic information. Some genes, for example, TET2, you wonder why is it actionable only some of the time? So as two examples, if a patient presented with unexplained low blood cell counts and we found a TET2 mutation, that would qualify them as CCUS, the clonal cytopenia. However, we did encounter patients who met the WHO criteria for MDS. In that case, if they have a TET2 mutation, it wasn't important for diagnosis. It's also prognostically neutral, so it's not really a good or bad gene, it's sort of in the middle. And as of yet, it doesn't impact treatment decisions. So a lesson from this is that actionability can be difficult to interpret, can be open to wide definitions, but the clinical and path context is important. And so what we do in some of these cases is issue an addendum report where after the fact, all of the molecular and cytogenetic investigations are appended to the case and a revised diagnosis is provided to the clinician and patient. Okay, coming back to subthreshold disease. So in our set, we found 64 patients who presented with suspected or subthreshold for a myeloid cancer. Because of the NGS, we were able to detect clonality in 55% of them, which either put them into a CHIP or CCUS category, and in 45% we found no variants, which could indicate that they have some other less sinister cause. We don't cover all of the genes, for example, but we do cover the most ominous ones. So the questions now that we're faced with and others around the world is, okay, now we've identified someone as not meeting the World Health Standard, but having a clonal cause of the disease. So should we follow them? How frequently should we follow them? Should we optimize their health, for example, cardiovascular disease risk, which I'll mention in a moment. And those without variants, can they safely be discharged from a hematologist practice back to the family doctor and only sent back to the hematologist if counts plummet again? So as we accumulate more cases, we plan to prospectively follow and we'll be in a better position to look at outcomes. So in the second part of the talk, I want to mention now, we think of the life cycle, the earliest life cycle of myeloid cancers, back to the future, if you will, to the origins. Now, this work started in Toronto with the identification of pre-leukemic stem cells by John Dick and his group. These were back-to-back papers in the New England Journal of Medicine in Boston, where they looked at 30,000 healthy adults, sequenced their blood. And what they found was that as people age, and especially over the age of 60 to 70, you could start to detect cancer driver mutations, blood cancer driver mutations in their peripheral blood in apparent healthy individuals. These are small clones though, so the average variant allele fraction is 10%, meaning likely only about 20% of peripheral blood cells carry the mutation. This is associated with increased risk of heme cancer. And look what pops up as the top 3 genes. So the DNMT and TET, the epigenetic regulators, and ASXL1. To conceptualize this visually, what this is meant to show is that hematopoiesis is normally polyclonal. There are several stem cells, a few thousand, contributing to blood cell production in a lifetime. They may acquire mutations, such as this green one on the bottom, that don't impart an advantage, but that mark their progeny. But occasionally, stem cells will acquire a mutation that imparts a selective advantage. And so the first step is this clonal hematopoiesis or CHIP. Then subsequent mutations can lead to progression to diseases like MDS and AML. To keep in mind though, the risk, if you're identified with CHIP, the risk per year of transforming to MDS AML is only 1% risk per year. So there was caution when these studies came out to say it's not appropriate at this point. We're not asking to sequence everyone, but at the same time, this could represent a tremendous opportunity to understand the origins if we do some more investigation. So with that 1% per year, you think, oh, what's the big deal? Is this just a sheep? But what I hope to show you in the last few minutes now is that it may be a sheep in wolf's clothing. So a big unexpected finding was that CHIP was associated with all-cause mortality, not just heme cancer mortality. And this was attributed to diabetes especially, and coronary heart disease and stroke. So the big question everyone had was, why do mutations in blood cells cause an increased risk of heart disease and diabetes, for example? So here's the punchline. So TET2 and some of the other CHIP genes are terminators in that they are there to suppress and dampen inflammation. So one story of my early lab is that getting scooped and frequently. So we were among the first, so there was a Nature paper that came out. We were among the first groups that identified TET2 as being important for restraining inflammation, particularly in monocytes and macrophages. And so TET2 inactivating mutations take the brake off the inflammation control, and you get rampant inflammation. And that's shown here in our data. So this is nanostring data looking at flox, just wild type control, essentially TET2 peritoneal macrophages versus knockout macrophages. And these are spontaneously producing a host of pro-inflammatory cytokines and chemokines like IL-1 and IL-6, for example. And others have been finding this as well. So the TET2 clone imparts a stem cell advantage. It skews towards monocytes and macrophages that are inflammatory, and they infiltrate throughout the body. Another scheme that they have is that in creating an inflammatory environment that suppresses normal hematopoietic stem cells, or HSCs. So here's a colony plating assay where we plate and replate HSCs from wild type and knockout mice in the presence of increasing TNF-alpha concentration, another inflammatory cytokine. In green, the wild type stem cells get suppressed in this harsh inflammatory environment. Paradoxically, the TET2-mutant cells are able to thrive and expand in an inflammatory environment. So there's an advantage to these cells to creating an inflammatory environment. And this is the punchline of two high-profile Science and New England Journal papers, stem cells going rogue. So what happens with the heart disease connection is that these mutant stem cells, their mutant progeny, monocytes and macrophages, also carry the mutation. They infiltrate heart plaques, cause inflammation, and aggravate atherosclerotic cardiovascular disease. This is work that we have at Blood Advances, hopefully will be accepted soon. This is looking at 400 elderly participants at Baycrest and Sunnybrook here in Toronto. And we've been looking at inflammatory cytokines that associate with CHIP. And so here we're showing all of CHIP and then stratified by mutation status. The top cytokine we see being associated with CHIP in humans with about a 2-fold or so increase is IL-6. And this was kind of satisfying to find based on the mouse studies with TET2 knockouts that IL-6 is the lead one of the lead cytokines implicated. And so it appears that this inflammation connection with CHIP also holds true in humans. And because of this, we're wondering if CHIP is associated with other age-associated diseases. Okay, close to wrapping up here. Now, what about CHIP clinics? Should we be profiling people for CHIP? And so this is on Twitter. I just noticed that Memorial Sloan Kettering is doing this, starting to do this. And I understand from discussions today that similar initiatives are underway here in Toronto. So should we be doing this? It's already starting. And the idea here would be to do surveillance to optimize cardiovascular health, for example. And the last thing to mention is that now it's becoming more possible to predict who with CHIP or ARCH is going to develop acute myeloid leukemia. So this is work done by Sagi, Abelson, and Philip, and Loren, and John, and a host of others. Here they looked at the EPIC cohort in Europe. They identified 95 people with who went on to get AML with 400 or so matched controls and a validation cohort. And I'm probably not doing this total justice here, Sagi, but basically people who are bound to get AML with CHIP have a higher proportion of cancer driver mutations, higher number of mutations, higher VAF, and are enriched in certain mutations. And so they're beginning to develop predictive models now based on the mutations, but also based on widely available clinical parameters that someone would get at a family doctor's office or private blood lab, for example, Life Labs. And so we're now beginning to develop models of better understanding who might develop AML. And so how might we mitigate this risk? So here on the bottom is showing a TET2 insufficient cell with increased leukemogenic properties. Vitamin C, it turns out, is a cofactor for TET2. And so there were high-profile papers in Nature and in Cell showing that vitamin C in a TET2 heterozygous mutant state can dampen some of the leukemogenic potential. And with collaborators, including Stephen Chan here in Toronto, we're exploring synthetic lethality screens for TET mutants, looking for currently approved drugs that can increase the expression of the wild type copy of TET2 and the potential to sensitize TET2 mutants in other ways. And at meetings, we're hearing that similar strategies are underway for other mutations associated with CHIP. And so maybe targeting the clone at the earlier stages could offer some risk mitigation and health optimization. So in summary, in the first part, I hope to show you we're beginning, not as scientifically exciting, but necessary, identifying shortcomings of our ability in diagnostics and prognostics and how NGS can affect that. And considering the adaptive oncology and thinking of the early life cycle of cancer, identifying the origins, understanding better how people progress to leukemia, how they get comorbid diseases, potentially doing health optimization, and maybe down the road cancer prevention. So I especially like to thank Dr. Bartlett and members of the Transformative Path Diagnostic Development, Jane and Melanie, Philip, Lars, Paul. I should have Kim on here as well. I'll be beginning to collaborate with Philip's group. Members of my lab, so this work especially was done by Brooke and Christina, and the mouse work by Alina and Samuel and Alyssa. Harriet Philauder, David LeBrun, and others at Queen's, and some of my collaborators in the OncoMind network. Thank you very much.